Baba Booey.
All right, let's knock out this one more.
Yeah, we can probably. Yeah, I gotta go look for an accent wall.
An accent wall?
Yeah, I guess that's what it's called.
Accent. What are you getting? Paint?
I'm thinking of doing it in a different way.
Don't tell me you're doing shiplap.
I was gonna go the rug route.
Oh.
Where you like pin a nice like oriental rug
to the wall?
Yeah.
Interesting.
Yeah, it's a thing. So anyway.
I'm David.
And I'm Matthew.
And this is the Handoff Report, a podcast about the cool stuff nurses learn in nursing school and why it matters.
And more.
Today we're going to talk about Introduction to Nursing Ethics, which you learn about the first semester in nursing school. It's a bunch of terminology that kind of just helps you know how to think as a nurse in terms of your ethics. But to me, they just all sound like the names of homeschool kids. Like justice, veracity.
Huh. I didn't think of it that way, but yeah, I guess that...
Time for dinner.
It checks out. It checks out.
Can you imagine like homeschooled nursing kids being
named like non-maleficents? Well, remember there's that movie, right? With
Maleficent.
Yeah, with Angelina Jolie. Yeah, she's like a raven or something. I don't know.
No, her sidekick's the raven.
Oh, okay. I didn't see it, but...
Not a sponsor. So, but coming to Disney Plus July 17th. So nursing ethics is basically just a set of principles that talks about the rights of the nurse and the rights of the patient.
It's like a framework that you can start building off of.
Yeah. And so all nurses are taught this. Let's start with autonomy. That might be arguably the most important one. This word autonomy. It describes the patient's right to receive the care that they want and the way they want. It's letting the patient be in the driver's seat of their healing process.
And I wouldn't say this is a nursing specific thing, but it's definitely emphasized for nurses to be kind of the promoter of this type of thinking, of autonomy.
Right. The nurse has to proactively make sure the patient, feels empowered enough to take charge. A lot of times, because of how vulnerable they feel, they relinquish that autonomy, but they should have it because that helps with the healing process. In an ideal setting, it would be a lot better for the patient to make decisions instead of kind of just being told what to do, right? So that's what autonomy is about. Autonomy is saying, hey, if I go into cardiac arrest and I don't want to be resuscitated, then that's my right to not want to be resuscitated. If I am a Jehovah's Witness and I don't believe in receiving blood products that didn't come from my own body, it's my right to not want to receive that kind of care. It would be a breach of autonomy to force something on a patient that they don't want. Patients can and unfortunately are sometimes bullied into receiving care. That's where I would start when it comes to nursing ethics. The patient is the boss, Let's move on to fidelity. Matt, what is fidelity?
Isn't that
You wouldn't know, would you?
I passed my boards. I don't need to... No, it's... Isn't it keeping promises?
Much like with marriage, it's about keeping promises. Fidelity is when you say, for example, oh, sure, honey, I'll be right back with your
popsicle.
With your popsicle or your ice water. And then if you said that kind of just to have them shut up and you really never come back, then that's a breach of fidelity. You don't want to be untrustworthy when it comes to your relationship with your patient. The patient needs to be able to count on you. They're not stupid. Patients totally know when you just don't enjoy being around them, or if you're constantly like hedging your words and not really keeping with what you're just saying stuff to get them to be quiet or go away. The patients know, and it's important, if you want there to be a trusting relationship between the two of you, to keep your word.
To practically like apply it in a hospital setting, it can be really hard because, like, you know, you're having to worry about a bunch of different things at one time. So if you kind of you like get stuck in a room or something like that, you feel like you just need to say what you need to say to get out of the room, but you have to look at it in a broader perspective than that.
Yeah. This one time in the emergency department, because I speak Spanish, I went in and talked to a patient who was very agitated and had a lot of questions. For some reason, she didn't like her nurse, who was this other gentleman. And so I went in and I spoke in Spanish, and we kind of just talked out her grievances. And I told her I would go voice her concerns with the nurse manager, and that we would follow up with her on that. So I didn't say I would follow up with her on that, but I said we would follow up with her on that. That was the thing to say. She had concerns about her nurse. So I went. The other nurses already knew her concerns. She was just like trying to say this to as many people as possible. She had some kind of psychiatric thing going on where she's, I think, really paranoid about everybody. So she kind of didn't trust anybody there, unfortunately. And so because I was busy, I didn't, immediately come back with the charge nurse, who's also super busy, and just start saying things that she wouldn't believe anyway. So because I didn't come back fast enough, I'm pretty sure that agitated her even more, and she stopped wanting to talk to me the rest of the shift. And so, I say that story, and I really don't feel bad about what I did. There was nothing else I could have done, really, and it is what it is. But I can definitely identify how, from the patient's perspective, I wasn't faithful. And that agitated her and made things worse for her experience. So, and, I took that lesson to heart for in the future, maybe not over-promising and making sure I follow up if I end up, saying I'm going to do something.
There's a sweet spot and where you can't say certain things, like you're legally not able to say certain things, and you have to find it. And I think that comes through experience, but this is a good framework to have of like always keeping your promises. It's a good thing to base your decisions off of.
So we have autonomy and we have fidelity. The next one is veracity. Veracity talks about not lying to the patient, which again sounds super straightforward, but there's lots of instances where in your judgment you might think it's of some benefit to hold something back from the patient or lie to the patient to avoid some kind of conflict or something, but most of the time that'll just make things worse. And so I think one example of this for me was that in the emergency department we had a patient flown in on a helicopter from far away, and she didn't have any identification on her when she got to the unit. So she was Jane Doe to us. And so we had to contact her family. We just didn't know who she was. Eventually, I think whoever admitted her to the hospital did some digging and found out who she was. And then we were able to find her relatives and call them. And they knew that something was going wrong with her because they were with her when she collapsed. But they lived like an hour away. So they started driving. We tried to resuscitate her because she was in cardiac arrest, but it was unsuccessful. The nurse and I had to face a decision. We needed certain permissions from the next of kin to move on with the end of life care. But we didn't want to break the news that the patient had died while they're driving, because the shock and distress from losing a loved one now puts them in danger, because that's really hard to receive that kind of news while you're supposed to be focusing on driving. So the nurse and I had talked to a bunch of other folks. We consulted doctors and nurse practitioners, like, hey, they want to know how their loved one is doing, but we want to protect their safety by not telling them that their loved one has died while they're driving. I love the way that my preceptor eventually put it. She got them on the phone while they were driving. She said, she's here. We did all these measures. Unfortunately, we do have some bad news. And so we need you to get here, and we will give you a more detailed account of the bad news when you get here. And so that was very, very difficult. Once they did arrive, we told them that their loved one had died. Always tell the truth, and don't be afraid to ask other people to help you with how to tell the truth if it's going to be something difficult to say.
Especially starting out, because you're not exactly sure how to word things and say things in a way that makes sense. And like you're saying all that you can, and things you can't say you're not saying. So yeah, I would utilize those resources, because I mean they are there to help. And I think if you make an effort to be a learner, then they appreciate that, and they'll be more than happy to help you with that.
Now, there are a few gray areas with veracity. I don't think I've really figured it out for myself yet, but there are some instances where nurses will trick the patient into taking a medication, and that is super dicey. Whether it's a really old patient who you kind of just crush the med and put it in their pudding in order for them to take it. You never want to just out of laziness default to not telling your patients what you're doing to them, right? Because I think that also breaches veracity. But, you know, if they're really resistant and it's something that's life-saving, don't make decisions like that by yourself. It has to be a coordinated thing. Really just make sure you're protected legally. And that reminds me of this one time a patient had to be sedated with haloperidol, but the patient, you know, was going to be combative about it, right? The patient doesn't want to be sedated by this large needle. And so the charge nurse came in without the patient noticing. The charge nurse showed everyone in the room that she was holding a needle full of haloperidol. And so we all knew what the plan was in our minds. We all knew that there was going to be this moment where she would inject the patient with it, and then we all had to kind of hold her down when she reacted to it. So she came in and she was like, "Hi, sweetie. Can I check something right here? I think I'm noticing something's wrong." Bam! She injected the patient super quickly, and of course the patient hated that. She was screaming and kicking, and we all had to keep her down. But that is one thing where it's like, she lied to the patient about what she was about to do, if you think about it, and there will be those gray areas in nursing. So let's move on to the next one. This $10 word, beneficence. I think we should talk about this by comparing beneficence to non-maleficence, since they sound the same. At first it seems stupid because they sound like they mean the same thing, but they don't mean the same thing. Beneficence means you're actively doing something good for the patient. Non-maleficence means you are actively not doing something harmful to the patient. So the key word there is actively. If you're actively doing something good for the patient, that would be actively giving a medication on time, right? Non-maleficence is when you're actively preventing harm for the patient. It sounds like you're saying the same thing by saying do good versus not doing bad, but those are just ethical distinctions.
It's the intention of it too, of like what you're doing and what you're preventing.
Yeah. And so you'll get questions like this where nurse whoever catched the student she was precepting was about to give double the dose of morphine and stopped her. This would be an example of non-maleficence because the nurse prevented potential harm. Yeah. It's not something you need to know on the job. This is kind of stuff you mostly need to know for your board exams. But consistently, exams and schools and everybody, they really want to know how much you respect autonomy. I would just keep going back to that one as the one that matters the most. How much you respect and honor and revere your patient's autonomy is a great measure of your quality as a nurse.
It's a good indicator of a lot of other aspects of your care.
And if you think about power dynamics, the nurse is not the vulnerable one in the situation, right? The nurse has all this knowledge about disease prevention and disease treatment. The nurse has all this knowledge about safety and infection and all of this stuff in their heads that, makes them have a lot of agency, right? The nurse could if they wanted to, probably just do all the treating themselves. But that would be an abuse of power. These patients are our clients. They're the ones who are in there vulnerable. They're scared. They don't know so much, and that might be what is scaring them.
In pediatrics, this is especially important because you'll have kids come in and you hear this over and over and over again, but that the parents are the best knowledge source on the kids. So they know what's normal, like they know what the kids' habits are and how they act. So you have to listen to the parents and promote that kind of autonomy within the family. And that's something you hear over and over and over again. And it's so important in pediatrics, especially.
I remember a question preparing for the NCLEX about how a parent wanted the nurse to change the diaper for their baby. And I thought that was really interesting because if the patient is supposed to be the autonomous one, right? Wouldn't autonomy be that, yeah, the patient wants me to change the diaper, then I'll change the diaper, right? Well, this particular question, I think, was just trying to trip me up. But the correct answer was that no, the right thing to do is to maybe teach them how to change a diaper, or say, here's what we'll do. You change the diaper, but I'll watch you in case you have questions or if you want me to be present. It is autonomy because what did they want? They wanted help changing the diaper. But as a nurse, you kind of just wisely made sure that they weren't just absolving themselves of responsibilities. Mm-hmm. You're helping them still, but in a way that improves their healing, so to speak.
The nurse is only a temporary solution in that case.
Hospitals have ethics committees. So whenever, and sometimes nurses can serve on these committees. These ethics committees can be consulted by the nurse whenever something has gone down and the nurse just wants help with the decision making on how to move forward. And say, for example, that a husband that is mute because of some kind of injury, he doesn't want certain kinds of care, but maybe his wife does. And the wife might be the healthcare proxy, meaning she's the one who's legally designated to be allowed to make decisions if the husband isn't able to communicate decisions. So I saw this in the hospital, and it was a real ethical question for the nurse. And so she consulted some doctors and the ethics committee, because she was saying, I think the patient, even though he's mute, he can communicate yes or no really clearly. He's not, he has his cognitive abilities. He just has an injury that doesn't let him speak. And my understanding is that he consistently doesn't want this treatment, but the wife thinks that she has the rights to say and override it, that no, he's supposed to have these treatments. And so she consulted the ethics committee, and the ethics committee, they think about these things. They think about autonomy. They think about fidelity. They think about beneficence versus non-maleficence. And they use all of that to try to make the most ethical decision for the patients. It is all about the patients. It's not about whether the nurse did the right thing, or if the doctor's happy about it, or if the nurse practitioner thinks it'll be the best thing for the patient. It is all about the patient and their rights to the kind of care that they want. But sometimes it's not that easy. Well, I think that
pretty much sums it up.
That pretty much sums up an introduction to nursing ethics. I've been David.
And I've been Matthew.
And this was the Handoff Report.